I think we're going to go ahead and get started. I noticed that the people are rolling in, but it's somewhat slow this morning and get everybody into the webinar. So welcome. I think this is session number 22 of our Hopkins Center for Global Health COVID-19 seminar series to identify strategies to support the COVID-19 response in low middle income countries. And it's been quite a journey. Today we're going to talk about key populations, and we are joined by three very outstanding speakers. Also, before we get going, just to mention some housekeeping rules or updates. From next week, actually from this Thursday, we're going to move to once a week only session based on the feedback we receive from our participants. So we'll be on Thursdays at 9:30 to 10:30 moving forward for the months of July and August. And at the end of August, we'll reevaluate what the needs are. We have some interesting sessions looking at the pediatric response to COVID-19. We're going to invite some of our speakers from critical care and therapeutics to come talk to us also and provide some of the latest updates since we first started this adventure. So we love hearing from you. So thank you for all of you who are introducing yourselves to your colleagues in the chat function. Please make sure that your settings say all panels and attendees. While I love to know who you are, I'm sure our fuller audience will also appreciate it. And then questions should be posted in the Q&A box. I'll be moderating today's session, and in about 20 minutes, we'll go through the questions and try to answer them as best we can. Amrita, feel free to also answer written responses to questions and answers if there's anything that you feel like we can address in real time. So without further ado, let me introduce to you our three outstanding speakers. So first of all, starting with a global lens of how the COVID-19 pandemic has impacted MSM will be Amrita Rao, who's a PhD student in the Department of Epidemiology. She'll be followed by Dr. Stefan Baral, who's an associate professor in epidemiology and leads some of the key population work here at Johns Hopkins. And he'll be presenting some data from the United States on the COVID-19 pandemic here. And then we're honored to be joined by our partner in Senegal, Dr. Douda, who is the executive director for Endosante in Senegal. And our goal here is for him to present some of the innovative strategies that they've identified to support key populations in an LMIC setting. So hopefully there'll be some great pearls and wisdom for us all to take home. So without further ado, I'm going to hand over to Amrita, and then I look forward to the Q&A at the end of the session.
Sounds great. Thank you for that. So can you all see my screen? Yes?
Yes, we can.
Okay, great. So thank you. I'm going to be talking to you today about interruptions to HIV prevention and treatment services as a result of the response to COVID-19. These are results from a social media-based sample of men who have sex with men. Briefly, I plan to open with a few details on the goal of this analysis, discuss the available data sources and methods used, and then finally discuss the main findings and implications for service delivery. So as we've begun to understand, efforts to curb the spread of COVID-19 have successfully slowed the growth of new cases. These mitigation strategies have also resulted in unprecedented disruptions to society, and the impact of these strategies on routine healthcare delivery is still largely unknown. Gay men and other men who have sex with men may be particularly vulnerable, as these mitigation strategies consistently appear to exacerbate existing disparities. So the objective of these analyses was to assess the relationship between the stringency of COVID-19 mitigation strategies and interruptions to HIV prevention and treatment services. Data for this study were collected through Hornet, a free gay social networking app with over 25 million global users and 4 million active users. Hornet is the #1 app for gay men in France, Russia, Brazil, Turkey, and Taiwan, and is rapidly expanding elsewhere. Hornet serves as a platform not only to connect with others, but also to learn about what's going on in the community at large and share content. So between April 16th and May 4th, 2020, active Hornet users were invited to participate in a survey with a series of questions related to the impact of COVID-19 on a range of economic and health indicators. Hornet users were eligible for this study if they had been active users of the app for at least 1 year. And countries were included in these analyses if they had at least 50 individual responses. So a total of 2,134 individuals were included from 8 countries: Brazil, Canada, France, Indonesia, Mexico, Russia, Taiwan, Turkey, the UK, and the United States. Individuals were asked a series of questions related to the effect of COVID-19 on HIV prevention and testing. So for HIV prevention measures, all participants, regardless of HIV status, were asked about their access to a series of HIV prevention services, including in-person HIV testing, HIV self-testing, pre-exposure prophylaxis for HIV prevention or PrEP, and condoms. The questions began with the prompt, whether you need these or not, do you feel you have access to HIV prevention strategies during the COVID-19 crisis? And in addition to this social media-based survey, data on the stringency of COVID-19 mitigation strategies were obtained from the Oxford COVID-19 Government Response Tracker, or the OxCGRT. The OxCGRT tool collates information on indicators of government responses, and these indicators relate to containment and closure, economic policies, and health systems policies. These indicators are then aggregated to create different indices to measure government action. So here we show the Government Response Stringency Index. This index is based on 9 of the total 17 available indicators, and primarily relate to containment and closure and health systems indicators. So based on an aggregation of the scores on these various indicators, countries receive a score between 0 and 100 on the Government Response Stringency Index. So given that the survey responses were obtained between April 16th and May 4th, stringency scores were assigned based on government responses recorded as of April 6th, so before any of the survey responses were collected. And we did assess different dates of recorded government responses in sensitivity analyses. So zooming in here on the countries that were included in our analyses, stringency of government response scores for April 6th ranged in value from 27.8 in Taiwan to 90.7 in France. And just briefly, the effect of country level stringency on access to HIV prevention was estimated using GE Poisson regression. So among included men, the mean age was 38 years old, with older men being from Canada and the United States. 18% of the sample were living with HIV, and 13% reported having no health insurance whatsoever. 57% reported some interruptions in in-person testing, 56% for HIV self-testing, 55% for PrEP, and 14% for condoms. So looking at the results from our regression analyses, for every 10-point increase in the stringency of the government response to COVID-19, there was a 10% reduction in access to in-person testing, a 9% reduction in access to PrEP, a 2% reduction in access to HIV self-testing, and a 6% reduction in access to condoms. So here we learned that more stringent government responses were associated with decreased access to HIV services. And innovative strategies like mobile service delivery or telehealth may be needed to minimize the service interruptions from these types of government responses on MSM communities and ensure continuity of care. And to wrap up, I'd just like to thank all the collaborators on this work. So the COVID LGBT Disparities Working Group, in particular, Sean Howell and Sarah Wallach, and the folks over at Oxford who created this government response tracker, and of course, to all the participants. Thanks. So I guess I'll be now sharing Steph's slides.
Yeah.
Second.
Great. So thanks, Amrita. So moving from global to a little bit of an earlier survey, and I think in many ways showing sort of consistency of what's being observed among gay men and other communities in international settings and dynamics across the United States. And so, you know, as we're waiting for the slides to come up, great. I'll note this presentation is being given on behalf of myself and colleagues at Prism Health at Emory and the team that runs AMIS. And this is from this is work that has now since been published and was done with Travis Sanchez and Maria Slodorzinska and Mona Rai. And so great, next slide, please. So I'll just say, you know, I'll just present a little bit about what AMIS is and why the platform allowed us to kind of start surveying people so quickly, the methods of the online survey, and just some results and thoughts about next steps. Next slide, please. So AMIS is an annual survey that is done for about 10,000 cisgender MSM across the United States, and it's been going on since 2014. So it's in its 7th year. And the idea is to really assess trends in HIV risk practices, use of testing services, access to prevention services, and increasingly focused on PrEP, but other services, obviously. The eligibility is being a cisgender man, being 15 and above, being a US resident, and basically ever having had sex with another man. The recruitment is done through ads and multiple sites and apps, and those who have previously participated are invited specifically. There are no incentives given for just the participation in the survey, although when we collect self-collected biological specimens, including blood or hair or fingernails, etc., people are provided an incentive for that. The core survey includes, you know, demographics and sexual substance use and HIV testing practices, HIV prevention use, mental health, and a real focus on stigma and discrimination, which is where the support comes in. And I'll note that we had done our last round of AMIS in December of 2019, so presented you know, an important opportunity to try it as a comparison point in terms of some of the early changes that we were observing. Next slide, please. So the context were, and I'll note this seems like an incredibly low number, but as of April 6th, we had 330,000 infections. I think we're at 2.6 million now in the US, but every state had already been impacted in April. It was concentrated in urban centers. I think people recognize at that time it was really New York and Chicago. There had been an outbreak in New Orleans, although that was slowing down. And so that was sort of the context, but there was also, you know, kind of these thoughts around more rural outbreaks or suburban outbreaks of COVID. And, you know, this is happening in the context where we've known for a long time in the United States and really around the world, I think probably many folks here are connected to this, that there are clear biological and structural risks that potentiate risks among gay and bisexual men around the world for HIV and STI related risks. And qualitatively in discussions with folks, there had been, you know, noted disruptions in both the access to PrEP and testing and treatment services for STIs and HIV. And so we just wanted to empirically assess this. Next slide, please. So the study goals were to characterize the impacts of both the epidemic as well as the response among MSM with and without diagnosed HIV infection. So those at risk for HIV as well as those living with HIV, to really inform what optimal approaches might look like in terms of engaging people more remotely with service delivery services as options. Next slide, please. So the methods were that we were to enroll 1,000 cisgender gay men between April 2nd and April 13th, 2020, with a focus on those, again, 15 and above across the US with a survey. You know, in addition to, you know, the sort of baseline COVID survey, we wanted to keep it short because I think people were being sent maybe a lot of different surveys. And so We assessed general well-being, sexual and substance use practices, HIV and STI prevention, HIV treatment, really to try to look at changes in those over the last number of months. We stratified analyses between those 15 and 24 and 25 and above, because our underlying or our kind of thoughts coming into this was that this was potentially going to affect younger people more. And we also recognize that there is a concentration of HIV incidence risks among younger MSM. So we looked at differences in the prevalence of adverse COVID-19 related impacts by participant age, and we presented those as prevalence ratios with confidence intervals. Next slide, please. So, the characteristics, I'll just note, we had a pretty good distribution of ages. About 20% of our sample were 15 to 24. And then you can see, a nice age range with about half the sample under 40, or more than half the sample, and about half the sample over 40. While we did relatively okay with Latino communities or Latinx communities, there was about 8% African-American participants, and then the majority of participants were identified as white, non-Hispanic. In terms of health insurance, which I think is increasingly becoming an important determinant of access to care, most people relied on private insurance rather than public insurance. And as a baseline, about 15% of the sample had reported food insecurity in the last 12 months. And so even before COVID, there had already been an element of economic marginalization that we know to be the case, especially among younger gay men often. In terms of population density, about 40% of the sample were from urban centers, and then we had a pretty good distribution of suburban and small medium metropolitan centers, and then about 10% from rural centers. Next slide, please. So I think just as some elements that we saw early were particularly among younger folks. So this was kind of, this was pretty prevalent across settings, but we saw, those that were 15 to 24 reporting increased difficulties in paying rent, having challenges in accessing the internet, and so decreased or less access to the internet. And again, this is April, so this is pretty soon after really things had taken off in the United States, or at least had been measured to be taken off in the United States. People were significantly, those younger folks were significantly less likely to be working, and also much more likely to have lost their job for a COVID-related reason. Next slide. Interestingly, there was no difference in terms of the numbers of sex partners. There was trends for maybe some decreasing the number of sex partners, others increasing. There was increased use, especially among younger guys, of using hookup apps to connect with other men, but not necessarily for in-person contact, but really just to engage with other folks, and the apps like Hornet, in fact. People did report, especially among younger guys, increased challenges in terms of accessing condoms, increased use of recreational drugs, and increased use of alcohol among younger MSM, but fairly prevalent across the sample. Next slide. Among younger MSM, and I think, to sort of highlight this, they reported challenges in terms of STI testing, challenges in terms of trouble. So there's general access difficulties, trouble actually getting an STI when they wanted one. For HIV testing, we didn't see significant differences, although again, it's kind of arbitrary. It was close to being significant. It was definitely a trend. We didn't really see, and then I should note that there wasn't significance in terms of the PrEP, but it's just also from a numbers perspective. But there seemed like there was troubles getting PrEP perspectives, but the numbers were relatively low. Next slide. So, I mean, I'll say, I think there's a number of limitations with, an online sample, but the main one really being about generalizability. But I think that, early what we were seeing were that, COVID-19, the epidemic and responses really created widespread distributions. And we know this, to economic resources, social networks, but also really of healthcare services. And there also appeared to be a direct impact on sexual partnering. So there seemed to be like disruption of existing sexual networks and creation of new sexual networks, which I think, needs to be studied in terms of what its relationship looks like with STIs and HIV. I think, from an economic perspective, it was, the effects were really being observed among younger MSM. So and the outcomes of that as well. So, you know, higher amounts of mental health challenges, higher amounts of substance use, alcohol use, but also increased likely to have lost their job or have less access to employment. And for those that were reliant on insurance for their healthcare services, it sort of further reinforced some of those challenges that were that might be a concern. And I think, you know, broadly what this tells us, and I think many are trying to do this now, is that, you know, we really need to think about how we're going to provide services remotely and effectively to these communities. And so telehealth and app-based service delivery for PrEP and HIV care, mailed specimens, so that we can keep understanding and providing these services, but with the recognition that we need to do that in using new models. And so obviously I wanted to thank the participants and also NIMH, who supports the underlying work, the stigma work with which this was done. Thanks.
Thank you, Steph. And then I think we're going to move on to Dr. Douda from Endesante to tell us a little bit about the interventions that they're currently implementing in Senegal.
So thank you very much for inviting me to this webinar. I'm going to share the experience from Senegal, but this is most likely the same experience that we're having in over 12 countries where we're working in West and Central Africa. So one of the things that is we have to know is that in most of the African countries, we were first hit by the economic impact of COVID before we witnessed the health impact. So because when it started in Asia and in Europe, we first felt the economic impact in terms of procurement, drugs, goods, and then money to be sent from abroad for migrant community in Senegalese migrant community or African migrant communities. And then before we got the first cases, government measures was applied in terms of lockdown, restriction of movement, and this has had a huge economic impact and social impact. So, and then we realized as civil society organization, NGOs working at the community level, that we had suddenly to face three burdens. One is to keep continuing with our own regular activities. The second with the COVID activities, and the third with the social issues that communities and our partner was dealing with. And then knowing the fact that in almost all of the country, the COVID healthcare services was set up from the HIV healthcare services in hospital and clinics, because those clinics were equipped and the staff was trained for HIV and was quick ready to take on the COVID cases. So it ended up with the lockdown of HIV services and disruption of different services, particularly those for key populations. One other element important on the context is that the first communication, the mass media communication that was done by the government was more focusing on the threat that the pandemic was and the number of deaths it could generate when the country is affected. So this has generated a lot of fear and a lot of stigma. And we have seen quickly, as the first cases was diagnosed, that people who were diagnosed positive and their family and their community in large was stigmatized and marginalized. the same type of stigma and marginalization that we have had and we have been facing with key affected populations, particularly gay men and sex workers. So this is the context in which we had to face with stigma, discrimination, socio-economic impact, as well as health impact of COVID. Next. And that's how we've been put in a situation where we have to respond. And the first organization who responded to the COVID pandemic was the HIV movement. The HIV, the organization that was dealing with responding to HIV, did develop quickly, even earlier than the government, community response to COVID, because we had to find a way to combine and to guarantee the continuity of HIV services with responding to the new pandemic, which is COVID. And that's how we quickly developed the response. But one thing that we learned from HIV was, while the government was pushing and developing a broad response, a more generalized response, we understood very quickly that what really matters in responding to COVID with specificity. That's how we develop very tailored response that focus on vulnerable group and vulnerable communities, and delivering very targeted services and focused services on those communities and then group. In the meantime, we were able to also reach out to key population and community stakeholders we were working with. One thing that was really extraordinary is that how we were able to mobilize quickly and the health system that already, the community system that already existed in contact tracing. And because the government system was also either by phone or contacting people or sending the police or sending the clinic personnel to trace contacts. Rather, we did use the community resources and the community system that we were using already to provide HIV response to trace contact. And it was really effective in a way that it was not done in a way that generates stigma and discrimination against the patient and the family that was affected. Next. And then one other element of the community response that was developed by civil society organization is that we use the fact that we were working in close proximity with the communities, and that's how we did customize the response and the information about COVID, as well as develop a treatment and information literacy for communities that are accessible using their own words, using also local language, and trying to destigmatize the COVID, and really positioning communities as at the center of the response to COVID rather than the government-led response. We also managed to mobilize people who were impacted by the COVID response in developing and trying to enhance local economy. So because we are in a context where most of the people, 99% of the people, live from daily basis income. So we did go and find the tailors and then give them, job from making masks, and then we develop a certain local economy. And what's most interesting is that this would help us to reach out to particularly key population and then involve them in the response as key stakeholders, and it provides them also to a certain extent a job and a source of incomes as a peer educator, as a peer navigator, or those who were working in design as a designer or as a tailor also was given a job in making masks for people. And the other thing is that we realized also something that was very important is about data. Government was collecting data more from the clinics, and the system, we felt the system was not reflecting the trend of the epidemic as it was seen from the community perspective. So we set up a system that was helping us to collect almost real-time data, where communities was giving us more information on how many families were affected, how many people they know, how many people was in contact, and help us to do a better tracking system than what we had with the government. So and then this has helped us to engage really with the government, saying, okay, we have to enlarge the possibility of having a better information collection and having a better case tracing system, as well as how do we monitor people who recovered and who had to go back to their family and their normal life without stigma and discrimination. And the fact that we have had the experience in integrating and mitigating stigma and discrimination from our HIV experience have also been very useful for us to develop a stigma-free response to COVID. Next. Next slide. So this is one of our team in one of the most affected area in Dakar, really doing door-to-door work, doing groundwork with community in terms of case tracing, informations, and also at the same time finding key population that was we were working with on our HIV response, who were lost to follow up, to come back, to bring them back to the clinic or to our mobile clinics that were delivering HIV services. So we did combine two. And what we have learned from this experience is that, looking forward, is that we are facing two challenges. One is, how do we catch up? How do we catch up? Because the health indicator, as well as, and particularly the HIV indicator, the number of people who are tested, the number of people who receive the HIV treatment will not be the same, will not be where we left it. So we will have lots of follow-up, we will have lots of treatment resistance, and we will have to catch up on where we left the HIV response, and continue to also develop new response and increase resources, as well as strategies to keep the progress that we were making in terms of access to testing, treatment for the most vulnerable people, particularly and specifically key population in this context. Next. Okay, next, no, so this one. And one of the response that we have developed, one of the response that we have developed, and that was very important, was the use of new technology, because we managed to keep the information, to keep the contact with key population, as well as as well as provide them with information about COVID using text messages, WhatsApp, using a website, and we developed several tools and that was adapted to the context, and then provide them with information. So, and this is the experience that we had from a civil society perspective, working at the community level in Senegal, and the same applies with many countries in West and Central Africa. Thank you.
Thank you so much. I think we covered a lot of different information over the course of the last 40 minutes. Dr. Douda, can I ask two questions for you? One is, can you describe a little bit further what the early warning system was that you had mentioned during your presentation, and how that was implemented and how that's been working out? And then my second question is, we've been hearing from a number of countries this phenomenon of, once patients go to a healthcare facility with suspected COVID, they're not being allowed back into their communities. We do have a session coming up in July and August about communication and destigmatization, but what were some of the strategies that your team in particular implemented to allow individuals to go back to their communities?
Up to me? Yes. I think this is a very good question. First, we had a program that while someone is tested positive and hospitalized, there has been a lot of work that was done not only with his family but the whole community, and then developing really a community response, having people to better understand what is COVID, how it is transmitted, and the huge impact of stigma and discrimination on people and their family. So, and this has been already, I think this is something also we have done a lot during with HIV. That's the same thing, same people, and then we in every area, very community where we were working, we've been working with religious leaders, community leaders, peer educator, and all those was mobilized in really preparing communities to live with COVID, and also to have people who come back and take and share their experience. In one of the tools in my last slide, there's one video that was developed, and we have only people who recovered from COVID, and it has been largely used, who are also sharing their experience and sharing the experience of stigma and the impact of stigma. And this has been really generated a conversation at the community level, where people realize that it's how, what can be the negative impact of stigmatizing people and their family, and how we can play a role. People who recovered from COVID can also play a role. And one example that was used is the fundamental role, the central role that was played by people living with HIV in responding to HIV. And that's one of the examples we always give in saying, if we value people and their experience in dealing with COVID, they can help us to better respond at the community level. That's one thing also, that's one of the strategies we did.
I think that's a strategy that many of the individuals here who are now grappling with these same problems could likely adopt. A question for Steph from Philip Rosenberg. Great presentation. Why the specific focus on cisgender MSM in your survey?
Sure. Yeah, I think a critical question. So AMIS has been designed to be very cis-oriented. There is kind of a cousin survey to it called twist, which is more trans-oriented. And part of that is just because the way that people have been traditionally enrolled, the types of ads that are used are very cis-oriented. The sites, you know, the social apps that are used are very sort of cis-oriented. And I think a couple of years ago, I will note there was a very lengthy discussion about trying to be more inclusive, and there was a discussion with leaders from trans communities, and it was really felt like having trans-specific surveys with more clear trans leadership was better than trying to integrate trans communities into a survey that was predominantly sort of cis-oriented. So I think it's critical, and I will note, I mean, I think in some of the other surveys and some of the things we're learning, there are like additional and kind of intersectional vulnerabilities related to gender identity as well that obviously weren't measured here. So I think the point's really well made. I think, you know, our design allowed for a rapid survey that again was very cis-oriented, but it by no means represents the additional and different vulnerabilities experienced by trans communities, trans men, trans women, and people on the non-binary continuum.
Thank you, Steph. I put a poll up, so I was just curious to see how many of our audience actually have the opportunity to work with key populations and what that focus is. So I'm going to let that continue running as only 15% of people have voted. In the meantime, I have a question from Sanu Dali. Thank you for this innovative presentation. Can anybody speak to whether the sexual behavior of young men has changed during the lockdown? And is there any data on that or anecdotal experience?
I'll jump in, and then I think others can answer as well. I'll say I think this is played out very differently in different settings. In some places, we're seeing like increased folks showing up with STI diagnoses, and so there's like more sex happening. In other places, I think there's less sex happening, and there might be, you know, and I think there's a relationship between the types of shelter-in-place orders that are underway, and I think that's even separate from sort of a global perspective. So I think it's probably hard to sort of generalize. Even within different cities, we're seeing very different perspectives of people like engaging just via apps and having more social engagements, and then just like kind of proof in terms of like just increased STI diagnoses, and some, as I was saying, disruptions in sexual networks, like maybe their traditional sex partners don't want to have sex and they're going out and finding new sex partners. So there might be some disruption in sexual networks that I think we recognize, you know, is associated with sort of new and different sorts of risks or opportunities. So I don't know that I definitely think that sexual practices have changed for many in the last number of months, but I think it's probably not easy to generalize in terms of like how people are having sex across different settings and even by communities within cities. I don't know if others want to jump in, but
just to add, I think this is part of the main focus of the COVID survey that's being implemented through Hornet. So I know other people in the group are planning to look at this in terms of partner seeking and disruptions in sexual networks. So hopefully that, I agree completely that it largely depends on the place and what's going on in the setting, but hopefully it's something that we can get more insight on.
Thank you. Dr. Douda, anything you would like to add?
you're muted, Douda.
What we have seen here is that during the first, first 1 month and half or 2 months, people was just locked down in their own communities, and for clear, the sexual network was disrupted, and we start seeing people fighting to survive, to have some means of survival, and then but what people who came back to our clinics, we start seeing STIs, and people who are saying that they couldn't access to lubricant, they couldn't access to properly to condoms, so it was difficult. So I guess after we assess it, if we formally assess it, my guess is that we will see a higher risk of HIV acquisition after COVID.
Thank you so much. I'm just going to end the poll and share the results with you. I think I found the results surprising. I'm sure I'll ask our panelists to comment on this. But it seems the majority of our audience today, although only 30 of you voted, seem to be working with sex workers as the main key population that they're engaging with. Did this surprise any of you? Does this seem like the focus seems to be?
I mean, I'll just say a few things about sex workers and COVID. And we've heard this from NSWP, the kind of international group supporting sex workers around the world, have done surveys showing that like a lot of like, you know, a lot of the sort of protections that have been put in place have actually not been, you know, put in place for sex workers. So like rent control has, you know, any places like businesses that in any way relate to sex work have not been protected, and people have been displaced. I think, you know, the way that people are engaging in sex work has been more challenged. And then we just heard yesterday that the Supreme Court didn't kind of throw out the anti-prostitution loyalty oath, which was something that many of us would have hoped, which equates sex work to trafficking around the world outside of the borders of the United States. So I would say, like, you know, today the sessions that Amrita and I gave were focused on LGBT communities, although there are obviously sex workers that are in that community, but many sex workers who are not. But it's to say that there have been very specific and real dynamics among sex workers, both economic, human rights related, and HIV and STI related that we didn't talk about here. And so it's great to hear that folks are doing that, and it would be, you know, great to have a session or discussion around it. So
Definitely seems to be an area of need. I'm going to move on to our last question. I mean, Dr. Dutta, I think I'm going to unmic you in case I'm not portraying your question appropriately. But it says, Dr. Douda, you mentioned using the most of the HIV-related systems to address COVID-19. How do you think these systems can be tailored for more generalized populations, HIV populations, and other high-risk groups? Dr. Dutta, we will unmic you in case you would like to clarify that question further. But I think the gist of the question is, based on the innovations that Endosante is doing.
I think you read it right. Am I audible?
Yep.
Yeah, so I was just wondering, I think you read it right. The question is, while we are using most of the systems, partnerships, which we had already established via our HIV work, and I see that in many countries where polio eradication related work had happened, Ebola related work had happened. So the huge community level partnerships, the prevention messaging, a lot of things which we had already learned, including issues of stigma and discrimination. Where my question arises is the way we had categorized the populations for HIV in terms of generalized and high-risk populations is very different for the COVID-19 scenario. And so in that scenario, using the same resources and the same systems, how do we address COVID? I don't know if I could clarify it any better.
Yeah. I think you know, when COVID arrived here, we had to use an existing system that was there, and a system that would shift the response quickly. And then we also realized that you know, responding to COVID we know from COVID that there are more groups that are specifically more vulnerable to COVID than others. As for HIV, there are groups that were more specifically at risk than others. So the same system, we have to categorize. I do believe, working for a number of years on HIV, that the more you are specific in your response, the more the higher impact you can have in responding to a health issue. So here also, we did at the community level really focus on people with lower economic conditions, people who were, there are many communities where in one house, you have 15 to 20 people working in the one house with 3 bedrooms. Right. So the level of risk of acquisition is not the same as other people who live in more privileged urban area in Dakar, for example, in Senegal. So we did focus on them. We did also focus on those areas. We did focus on people at a certain age. We did focus on families where there has been already cases of COVID cases, and this has been very, very helpful in how do you develop a specific response in a context where the information is available broadly, and when we realize that in those groups and those communities, they had very specific questions related to COVID, on how do they organize themselves, how they limit contact within their own compound, how do they keep earning incomes and not exposing themselves to the COVID response, and how do they deal with stigma and discrimination in the surrounding areas when there is a COVID. And then the other thing is that we realize also that they fear the same level of stigma in the health clinics and health system that many people who were also facing during for example, HIV, sex workers, men having this sex, being stigmatized in health clinics. The same people also who are coming from different areas also fear the same level of stigma, as well as they're facing stigma at the community level. So I do believe that there is an importance of getting of having a broad response information, broad system. But the more we target the response, and the more we are specific in responding to the COVID, the more impactful would be the interventions.
Thank you. Thank you.
Thank you so much. That was an extremely well thought out response. So we're at 10:26 and my Zoom call is being gate crashed by Anushka. I'll let her say hi to everybody. Say hi to all my friends. And she's practicing the potty. So on that note, I think we should call it a day. We look forward to hearing from all of you on Thursday. Alana Breek is going to be talking about digital health focused strategies, some of which Dr. Douda mentioned today, to help with surveillance and access to care during the COVID-19 response. Thank you everybody for joining, and especially to our guests from Senegal, Dr. Baral and Amrita Rao, soon to be Dr. Rao.
Thank you very much.
Thank you.